Hello and welcome to another episode of the Melbourne Athletic Development Podcast. Jack.
John, how are you?
Very good, because we are in our new space.
We are indeed.
For those watching the video, you'll see that we're in obviously one of the offices at our new building at 168 Hoddle Street. We obviously, for those people who haven't been in for a while, we do look forward to seeing you and welcoming to our new home.
Hopefully this isn't the way that they find out that this is where we're located. They've got an email or a text message as we've been trying to communicate to everyone that we have actually moved.
Yeah. So today, what we thought we would talk about is imaging and what correlation that has with the pathology itself and the pain presentation or clinical symptoms that people get.
Yeah, and I think it's probably more specifically related to more chronic, overuse, degenerative type presentations as opposed to acute traumatic type.
Yeah.
Because I think we need to separate those two out because we should approach how imaging fits into that clinical picture differently.
Yeah, well, I think for most people, we want to be clear that if you, for instance, are running along and you feel a big rip in your hamstring and you go and get a scan, it's probably going to show that there's tissue damage that resulted because of that specific incident.
And probably not just a coincidence that those two things are found at the same time, as opposed to, say, for instance, someone who's been having Achilles tendon pain, as an example, and then gets an ultrasound or an MRI and sees changes on that particular scan, and thinking about how much that's correlated to their current presentation.
Exactly. So with that in mind, obviously, as you just said, we're talking about more degenerative things that have come on insidiously over time and potentially have been going on for a long time and are more chronic.
Yes.
Now there's a number of different, areas of the body that I think we see these kind of degenerative presentations occur.
And we probably should talk about, go through each of them, yeah.
Yeah. On the surface at least, do you see them as being separate in the way that they kind of relate or correlate to, these presentations on imaging, or do you think that they're different?
Well, there's certainly some similarities in terms of a lack of correlation between certain chronic overuse or degenerative type presentations with imaging. So we're talking about certain types of tendinopathies. So that could be things like Achilles tendinopathy, gluteal tendinopathy, rotator cuff tendinopathy. That's very common. But we can also think about other tissue structures. So particularly when you think about cartilage or disc structures within the back, and thinking about the prevalence of disc degeneration within asymptomatic population groups being very high. We can talk more about that specifically. But then also looking at other joints, things like hip or knee, the prevalence of some type of cartilage pathology, whether that be some types of degeneration, thinning, sclerotic type changes in, again, asymptomatic population groups is really high. And I think the other really important one too is the prevalence of things like labral defects or damage within, say, hip pain as well. Because, again, the prevalence of, say, a labral tear is very common even in asymptomatic people, yet obviously a lot of people will come in with hip pain, may get a scan. And
then they say, yeah, I've got labral changes or some sort of tear in my labrum.
Yes, and become very attached to what the image findings are.
It's funny you say that. I actually had a patient the other day who said that, and when I looked at their hip and I did a clinical assessment, I was like, I don't know that the pain that you get is even associated with the labral, the labral imaging findings. They had two very small, what would be considered degenerative change tears in their hip labrum. And most of their function didn't relate to that. They weren't getting any of the, the more mechanical blocking signs. They weren't getting the sharp pain with deep flexion. They weren't getting a number of those issues in those, people would be aware of the Fadir or Faber positions. They weren't actually getting a lot of symptoms with that. So I felt like it was, people labeling the pathology based on the image rather than on the clinical symptoms that the patient was getting.
Yeah, I think the other thing though too is even if that pathology found on a scan is related to their current symptoms, what indication is that they need, for instance, surgery? Because they actually may see a cessation and improvement of their symptoms, return to full function, but still have that specific pathology on a scan if they did it 3-6 months later. So I think that's the other important thing to remember, that there may be a correlation. It may be indicative of, okay, you do have some pathology there. It does fit someone within the clinical picture, but just because it's torn doesn't need to be so-called fixed from surgery.
Yeah, well, as you know, it's funny because, well, not funny, but it's. I think this is related. You know, last week, as you know, I went to a conference looking at osteoarthritic management, and it was, you know, mostly surgeons and you know, people working in the biomedical sphere. And, you know, that was a really big discussion point on, okay, well, we know the one area that there actually is quite good evidence, well, there's probably two areas that have reasonably good evidence for mild or moderate osteoarthritis. We know lifestyle changes make a big difference, and we know tissue capacity development, you know, things like increasing strength in the localized area or through the chain, and improving range of motion and things like that tends to actually improve symptoms quite significantly. And then obviously there's other lifestyle factors like losing weight. And we can talk a little bit about that because I think it relates to one of the key factors that probably drives why people have pain in these chronic presentations, irrespective of the pathology. But the second thing was, which we know works, but it's pretty brutal, is actually having a joint replacement. And that's usually obviously associated with, you know, quite marked osteoarthritic changes.
And significant functional decline, and obviously pain that's impairing their ability to do normal daily activities.
And, you know, that's quite advanced joint disease. And I do use the term disease on purpose because that fits into the second part, which is what I just mentioned, and that's that we know that the metabolic health of that individual highly alters the pain perception and presentation and the symptomology that they get. And I think this is something that probably is a prognostic and a differentiating factor that as clinicians we can use to determine whether we think someone is going to, or someone's symptoms are more related to the pathology that we see on imaging or not. You know, like if someone is extremely healthy, they don't have any of these metabolic signs that would put them in, say, what we would consider a more pro-inflammatory state, whether that's localized to that area or more systemically. And the imaging comes back and suggests that there are changes. If we think that their metabolic health is good and most of those other tissue capacity factors and metabolic factors are good, then we can probably consider that those changes are relevant.
Yeah. I was actually thinking we've brought up a lot of different things here, so I think we should actually unpack a little bit.
Yes, sorry, that's my fault.
No, that's okay. Well, I think it's interesting to just even look at some of the statistics of the prevalence of some of these degenerative changes in asymptomatic populations. And I've got a study here, and I'll just actually describe the table. Well, I think it's actually good to hear the percentages of how prevalent it is. Well, so this is a systematic review done in 2014 by Brinjikli.
I knew you were going to bring this paper. Well, and I can never work out what the hell that person's name is.
Brinjikli. Anyway.
Who's the second author?
Yeah, so this is a study where they had asymptomatic individuals.
Yeah, so when we say asymptomatic, we mean people who don't have...
No pain.
Pain.
Yes.
They don't... If you said, you know, do you have any back pain symptoms? Do you have any shoulder... And they say no, okay, you're considered asymptomatic.
Correct. And they did an MRI to have a look at the structure of their disc.
In their spine?
In their spine, the structure of like their vertebral body, and even the structure of things like their facet joint, which is a joint that's more at the posterior element of the spinal column. And they had age groups from 20s to 80s. So if you look at the age group of 20s, the amount of people who had disc degeneration was 37%. Again, this is people with no pain. By the time you get up into your 80s, it's 96%.
Yeah, so everyone has changes.
Basically, everyone has changes. And
that's always funny because when you get sorry to interrupt there. I know that we've got an older patient who he was having back pain and he went and had a scan done. And I said to him, I was like, you do know that it doesn't matter what happens, it's going to come back with all sorts of things. And he's like, what do you mean? I said, and I actually brought this paper up, and I showed him, and I said, you do realize that at your age, and he's in his late 70s, that the likelihood of you having disc degeneration, of having, osteoarthritic changes to your spine is extremely high. Like, it's almost unlikely. The probability is that you would not fall in the percentage of people who don't have these changes.
Yes.
And he was like, I was like, so if we find something, it doesn't necessarily mean that's what's caused your current presentation.
And these findings are even seen in things like the prevalence of spondylolisthesis.
Yeah.
So, again, for clinicians, they'll understand what that is, but that's a stress fracture within your back where you actually have separation of the vertebral body to the what has happened at the pedicle, so the separation of the vertebral body.
Yeah, you get an anterior shift of the vertebral body, and it's usually obviously the more superior one shifts forward because of that.
Yes.
And sometimes they're developmental, actually. They're not necessarily
Completely.
due to like trauma or anything like that.
No, I mean, again...
I actually have a spondylolisthesis, actually.
Really?
Yeah.
There you go. Well, again, it's even 3% prevalence in the 20 age group. By the time you're in your 80s, it's 50%. Now, again, the point of highlighting this is not to suggest that if someone comes in with a mechanism suggestive of a stress fracture and you get an MRI and you find a spondylolisthesis, you go, oh, that just might be coincidental.
No.
This is where it's really important to think about, based on someone's clinical presentation, does it fit in with a scan if they've had one already? Because if you're just making the assumption that the scan is going to give you an indication of where the source of pain is, then you're going to be limited in the success rate that you have with interventions that you apply, because you may not be applying the appropriate treatment modalities. More importantly, it also may lead to inappropriate medical or surgical management, because it may be seen that because you have certain degenerative changes, maybe not so much in the spine, but again, these findings are seen similar within, say, rotator cuff tendinopathy. So a very common type of problem that a lot of people develop is non-specific shoulder pain. It may be related to rotator cuff tendinopathy, but we also know that asymptomatic people have a very high prevalence of rotator cuff tendinopathy as well. So that is people with no shoulder pain. The same is seen for things like Achilles tendon changes, where you get changes in the thickness of the tendon, the echogenicity. You can start to see some more chronic indications of chronic long-term pathology, like vascularization, calcification. But again, this is very prevalent within asymptomatic individuals. And again, as I was mentioning before, we see the same within cartilage, within the knee or the hip as a good example, where you start to see thinning of the cartilage defects, even things like sclerotic type changes or thickening of the subcortical bone, again, in asymptomatic people. So again, these are all indicative of osteoarthritis, but the people don't have pain. And I think that's really important to highlight. And then I think, as you mentioned before, we need to start thinking about, well, why is this the case? Why do we not see a perfect correlation between these pathological changes on imaging to someone's potential presentation? And this is where we need to make sure we have that distinction between the body as a machine, as a car, i.e. it breaks down and you repair the part, versus the body as a very complex biological system.
We have this conversation with people all the time, over and over and over and over again. But you can't see the body as some sort of mechanical structure. And
there is a mechanical elements to it, of course.
Well, I wanted to bring this up because actually, I think we did mention this, but we've had this conversation. We've had a few conversations with biomechanists recently.
Yeah.
And we keep pushing them on the concept of how much do you feed into the bio part of biomechanics and how much do you see it as a mechanical model? And it's become very apparent that a number of them see it very much still through a very mechanical lens.
Yes.
And there's not an issue with that in the sense that it applies, and for the most part, those models do actually create a good representation, but they are a representation that does not fully explain the biology side of things. And the reason that I bring that up is because if we were to see that as purely mechanical, and you actually just did, engineering type tests on, say, a bone or a joint or a muscle or a tendon, and tried to test their braking capability, they would fail a lot more often than they do. And the reason they don't fail is because we have an integrated system that does not necessarily function as 1 + 1 = 2. As we've spoken about a million times, but the relationships are not linear. And that's because there is the complex interaction that occurs between those different parts of the body.
I'll give you a specific example. 2 weeks ago, I was at the World Congress of Low Back and Pelvic Girdle Pain conference, and Mark Driscoll, who's an engineer from Canada, from McGill University,
Stuart McGill.
Is it with Stuart McGill?
Is it Waterloo?
Yeah, I think it's just called McGill University. I don't think it's named after Stuart McGill.
No, I don't think it's named after him.
But anyway, he presented his work, and he seems to be very interesting in that he understands that there is a biological component to how we look at solving the human system from an engineering perspective. And he's created a model where they dissect a cadaver and they dissect different he was looking specifically at stabilization of the lumbar region, and they dissected it, and through like a finite element model I think they used, they look at the anatomy and the
don't ask me what that means.
Well, I'm going to limit the explanation to saying it's a finite element model. Refer to Mark Driscoll's paper if you'd like further analysis. But the idea of that is I think it helps to describe how you see changes in the behavior of the tissue in isolation versus in combination with other tissue structures. Because what he did was isolate looking at the thoracolumbar fascia, looking at things like the erector spinae, looking at things like intra-abdominal pressure, and then other things like the obliques. And looked at when you just look at one of these structures in isolation, how much does it stabilize the lumbar spine, and comparing them, but then looking at what happens when you add them together.
That's cool.
And so
let me guess, they don't add up.
Exactly. You see a non-linear behavior in what happens when you add the thoracolumbar fascia with intra-abdominal pressure. It's not just 1 + 1 = 2. You're starting to see a non-linear behavior where there's
like
an
1 + 1
interaction.
= 4, yeah.
Correct. And so that highlights straight away where people might think, well, how does that make sense? But another good example, I think, too, and we've talked about this in the podcast before, is passive versus active stiffness, where if you just passively stretch tissue versus if you get the tissue to contract and then you try to stretch it to see its stiffness properties.
It's a different relationship, yeah.
It's not linear. It's not just because, the passive stiffness is X, therefore active stiffness is going to be Y. You can't necessarily make that deduction because the two things are not always linearly correlated. I mean, you probably could figure it out using some type of other equation, but it's going to be an equation that takes into consideration exponentiality as opposed to linearity. And the reason why we say this is because this helps us to understand why we see this disconnect between radiological findings and someone's presentation. Now, I also think too, it's important that when someone does have pathology on an image, it doesn't mean that it may not be indicative of future risk. And in fact, there has been some research showing, for instance, that if you have modic type changes on MRI of your spine, so modic type changes relates to things like edema forming in your vertebral body and potentially like things like sclerotic formation, it can be indicative of future risk of low back pain. Similar with things like tendinopathy, you might have indications of chronic degenerative tendon changes where you have an increase in the thickness, potentially some vascularization. That may not necessarily be correlated to someone's symptoms now. They may have, for instance, no Achilles tendon pain, but it can be indicative of future risk. And that makes sense because if you do see certain changes, it is going to change the mechanical properties of that tissue.
Well, here's the question. Do you start screening for that?
Well, that's a good question. I think more importantly we need to ask ourselves is, are there other factors we need to take into consideration that lead to some of these changes, and should we be screening for them?
Yep.
Because interestingly, a study I recently did a presentation for our clinic was a paper by Sean Docking in 2021 looking at things that explain the variance of Achilles tendon abnormalities in asymptomatic people. And when they looked at all the papers that have looked at this, the amount of variation you see is so large. It's like 0 to 80%.
0 to 80.
So exactly. But interestingly, what they did find is that there were a couple of things that they found from their analysis that were indicative of these abnormal changes. Because again, remember, these are people who are asymptomatic. They don't have Achilles tendon pain. And that was BMI. People with a larger BMI were more likely to have Achilles tendon abnormalities. So things like increase in thickness, vascularization, calcification, age, and then physical activity. So I think it's worth then thinking about, well, what does this potentially mean? And I think it gets to your point that you highlighted before. When people have a higher BMI, typically we're referring to people having more fat mass.
Yes. It's not. We're not really talking about people who are extremely muscular and therefore their BMI doesn't seem to represent their typical representation within that.
I was going to say, because BMI is a proxy for being overweight. That's not always the case, because obviously you have some people who have a high muscle mass and therefore have a higher BMI but actually are healthy. But typically is a proxy to say that you have more fat mass than you should, and typically associated with that in the general population is low muscle mass. And something that we've talked about before is fat mass, muscle mass are metabolically active. That is, they secrete chemicals and cytokines that flow through our body that influence our physiology. And it's actually one of the big benefits we get from doing physical activity, because when we contract our muscles, they secrete they secrete myokines. Myokines are cytokines that typically have an anti-inflammatory effect. And we hear time and again the issue of chronic inflammation being the root cause of most chronic diseases. That's why physical activity is so beneficial, because it helps to mitigate or reduce that low-grade chronic inflammation that the majority of us experience for multiple reasons. And conversely, people who have more fat mass are secreting adipokines, which typically are more pro-inflammatory in nature. This change in the chemical environment, and typically leading to an elevation of pro-inflammation, signals to our tissue how it remodels. And we know, for instance, that in tendons, an increase in pro-inflammatory markers causes things like tissue fibrosis and disorganization of collagen. And it also causes an increase in things like advanced glycation end products, which essentially describes how you get typically from glucose molecules, but it can also be from fragments of protein or fat, bind to other compounds and create an inflammatory nature that then causes disorganization of the affected tissue. And we see that there is a correlation between, for instance, tendon abnormalities with an increase in what are called AGEs, advanced glycation end products. So that helps to explain one part of the equation of why we see things like tendon changes. And in fact, similar things have been seen with changes within your cartilage, within joints, when we think about hips, knees, and the spine. The other one is age. But again, I think we need to consider that, is that an issue of aging itself, or is it an issue where, when you think about the general population,
health tends to decline.
And the other thing with that is people are not physically active. And it's interesting, again, in Sean Docking's paper, one of the other things I mentioned was physical activity, where high loads of physical activity increase the chances of abnormalities. But I think we need to tease out a little bit more about what that means in a second. But they didn't find that was correlated in older people. But when you think about it, that actually makes sense to me, because when you're older, there obviously are some people who are still physically active. There are some people who are not. But the people who are typically physically active are doing things like walking or swimming,
golf,
or low intensity physical activity, which doesn't really load your tendons.
Not at a level that the tendon will respond in a significant fashion.
Exactly, as opposed to younger people who are typically more involved in team sports, where they're running, jumping, change of direction.
Gym, yep.
And that's important when you think about tendon structures, also cartilage structures as well, because in order for tendons to adapt, the magnitude of load needs to be large enough to create a certain amount of strain of the tendon, which typically only happens at around 80-85% plus of your 1 RM max, so like your maximal voluntary contraction, or if you're starting to do stretch shortening cycles, because tendons obviously play a very important role in the storage and release of potential energy from ground reaction forces. So this starts to help make sense of, okay, we know that mechanical load is an important thing for tendon structures. And we know that, for instance, if you have a really high density of really high intensity training, that's when you're more likely to develop things like Achilles tendon pain, and if not managed well, start to see some of the degenerative changes. And that's why we need to really think about things like training load, and also even programming on an individual level to think of, is this person's programming appropriate for their sport and appropriate for their phenotype? Do you want to...
No, I'm just thinking what's interesting is, obviously, at the moment, I want to ask you about this. It's actually, I think, a good place to talk about it because it fits in with what we're discussing. But I'm noticing even with some of the athletes that I coach that have had ongoing, say, injury management issues, say if it's Achilles or whatever it is, of how variable their symptoms are based on, say, other lifestyle factors. So if they get stressed with work, if they're not sleeping well, if they're having, relationship issues, obviously that's going to cause an increase in stress hormones like cortisol, and that significantly alters your inflammatory and pain perception. Now, the interesting thing is we often see aggravations of flare-ups in those periods where they're either under a level of it's not actually even training fatigue. It usually is more lifestyle factors that are causing fatigue, but we see more symptoms develop.
Yes.
The thought that I had, and just then, which I would like to get your sort of thoughts on this, is, do you think that's not necessarily a change, obviously, in the structure? The structure probably already may have some degenerative changes to it, but it's when they do have these changes in, say, their inflammatory status is when we actually see symptoms increase. And their overall function is quite good unless that metabolic environment changes.
Yeah, I also think, though, the other important thing is when you're under stress, you get an elevation of your sympathetic output. That also changes your chemical environment. And I know, for instance, with connective tissue, so whether we're talking about fascia, tendons, ligaments, that elevation in the sympathetic output causes an elevation in a particular cytokine called TGF-beta1, which has a binding site to connective tissue that increases its stiffness. So I do wonder if you start to get more rigidity, because even though stiffness is quote unquote good, it's always a balance in the sense of...
You don't want too much, you don't want too little. It's
exactly.
the Goldilocks effect, yeah.
Totally. So do you start to get more rigidity within the tendon itself? But I think particularly with like the Achilles tendon, because the paratendon is essentially a bilamination of the crural fascia that surrounds the Achilles tendon. If that becomes stiff and rigid, does it create potentially some compression?
Yeah.
But I also then think about too of, does it also create other chemical changes within the subtendon, where if you think about the Achilles tendon again, we know that there are subtendinous portions that actually act somewhat independent of each other. They glide. But that gliding is also dependent on the loose connective tissue between the subtendons to allow it to be more like a lubricant and not create too much friction. Though we know with things like stress, that can change
the viscosity of
the loose connective tissue, because you can get changes in things like pH, whether that is also related to it as well. But I think undoubtedly too, the other one can be related to perceptual changes too, because again, that change in chemical environment will influence the sensitivity of things like, your dorsal horn, when you're getting some of that afferent feedback from the periphery to determine whether it is quote unquote normal or all of a sudden becomes nociceptive.
And I think what this highlights, that even in a very healthy individual or a very high functioning individual, your systemic health, your lifestyle situation, and the overall kind of stress on your system that is not related to the mechanical, biomechanical stresses you're under, has significant influence on your tissue behavior properties and or the likelihood of you perceiving pain.
Yeah, absolutely. And it starts to make sense then too of going back to thinking about the radiological findings is, why do we see such a high prevalence in asymptomatic people who may not necessarily have participated in physical activity that causes potential, maladaptations of that tissue, whether it's related to your tendons, your joints, whatever it may be? It may be because the signal or the maladaptation isn't related to the physical activity they're doing, it's related to other environmental factors. So the big ones related to what they're eating that either directly affects their tissue physiology because they're creating more of a pro-inflammatory environment, or indirectly because they're getting more fat mass over time. And I think we also need to think then too about there's maybe even certain nutrients we need to take into consideration, like maybe there is an inadequate amount of collagen consumption that allows optimization of collagen synthesis, or maybe other cofactors. And then I think the other big one then too is, and you mentioned this before, is tied in with diet, is metabolic health. Because particularly when we look at cartilage within joints, chondrocytes, the cells within cartilage that are responsible for synthesizing and controlling the extracellular matrix within cartilage, are very sensitive to your metabolic health. And what we're talking about when we say metabolic health, we're essentially referring to how effectively your mitochondria or your cells can create ATP and energy. Because remember, ATP is essentially the currency of life. Without ATP, we don't get a cellular function.
You don't live.
You basically don't live. And understanding that metabolic syndrome or metabolic dysfunction is so prevalent within the general population because the majority of us are not healthy. But when you have metabolic dysfunction, that causes things like chondrocytes to become senescent. They don't function. So they are already limited in their capacity to regulate cartilage. So if you further impair their function by being quote unquote unhealthy, you don't have the ability to then synthesize and regulate your environment to maintain healthy tissue. And that's a really important thing, because even if you're doing things like applying effective mechanical load to create the signal to the cell to go, okay, we need to actually synthesize new material to strengthen this tissue, it may not be responsive because it doesn't have the energetic capacity to upregulate certain genes and lead to the synthesis of certain proteins.
I don't know if we actually finished that discussion you had on that paper from our friend Bujinki.
Well, I think the main point we got across is that we have to understand that the prevalence of these things is extremely common. So, I think that's really important.
Yeah, just because you actually see these changes on imaging doesn't mean it's necessarily related to your presentation, unless there's been some sort of specific event that may have caused the trauma to that tissue.
And I think this is important for two reasons, because what we're really trying to make sure we avoid is unnecessary intervention. Because unfortunately, there are many cases of people getting surgery who don't necessarily have a good outcome because what they found on imaging is not reflective of the source of their pain.
Have you had many people go through that process? Have you had many patients where they've had surgery and you, in the back of your mind, have thought, I don't know if you're the right candidate for that, and then they have surgery and it was basically a waste of time?
Unfortunately, many, yeah. And it's actually just probably worth talking about. We've seen historically waves of an increase in certain types of surgery because that became the in vogue thing. So like I think of like in the 80s and 90s, all of a sudden everyone had meniscal tears in their knee, needed to get a knee scope and get their cartilage taken out.
Yeah, that's what happened in the NBA, wasn't it?
Well, I think it's happened all over the world, really. And then, and interestingly, it was actually from a Scandinavian country, because I don't think you'd get ethical approval to do it here. When they looked at they did a study of looking at surgery, doing an arthroscope to clean up the cartilage with the knee versus a sham surgery. So that is where they may have made it
tiny
like there's like a
incision.
little incision, but actually didn't do anything to the knee structure itself, and found that there was no differences in the outcome. Now, I say you wouldn't be able to get it done here because it wouldn't pass ethical approval, but obviously some countries, they allow that to happen.
Well, and we saw that in an important study, isn't it?
It is, and like we saw the same thing happen in the 2000s and even in the 2010s with hip, where we know that the prevalence of labral tears or some type of labral pathology.
Or even, that I think it's a big one, and I've had this discussion a lot recently with people. It's something you find on imaging. If someone who is involved in field-based sports, the likelihood of them, and I think our colleague Brady Green, who we've had on the podcast, mention this, but it's something ridiculous. Like, I can't remember the exact number, so I'm not going to quote a number, but a very high percentage of people who've participated in field-based sports for an extended period of time, say football, soccer, hockey, those kind of things, have changes to the morphology of their hip. And it became really popular to give people this diagnosis of femoroacetabular impingement.
Yeah.
The one that's more recently become really popular to give is...
hip dysplasia.
Yeah, which both of them... And then it's not nonsensical, but like it seems like people are going fishing using radiological imaging findings to demonstrate why people get hip pain. And the reality is often you find there's so many more clinical and functional features that they're missing that causes the pain than whatever underlying morphological changes that actually exist.
Yeah, well, again... there's a study being done, this is by Josh Heary, I think in 2018 from Lateral, where they looked at the prevalence of intra-articular hip pathology in asymptomatic people. And I've actually got the study here. So the prevalence of it in where is it here?
You're meant to be prepared, mate. Come on.
So the prevalence of hip pathology in symptomatic people was 62%, but in asymptomatic people, it was 54%.
So it's not a...
We're not talking about a big difference
here.
Was that
statistically significant?
Yes, yeah, this is a systematic review looking at it.
I'm saying, was that statistically significant?
Yes.
Or what that pathology actually led to...
Oh, you're talking about the differences between the two. I'm not sure if they actually looked at that.
54.
So we're seeing a very high prevalence of hip pathology in asymptomatic people. Mm. Again, it highlights, and correlates with some of the other research in other areas of the body, that there typically is a little bit more of a higher prevalence in symptomatic individuals than asymptomatic individuals. But we have to, again, be careful to make the diagnosis purely on the image. And I actually wanted to bring it up because I think the current in vogue one is hip dysplasia.
Oh, yeah.
But I think people need to be cognizant of what that actually means, because hip dysplasia itself, similar like to femoroacetabular or morphological changes like a cam or a pincer morphology, is not saying that you actually have pain. Is that maybe an indicator that you have a higher propensity or likelihood of developing pain? Yeah, potentially. But that in itself is something that isn't pathological. It's clearly something that's very prevalent and is something that's happened for a reason.
All right, we talked about, and I think people will probably have the clear point, right, from us, which is just because you have imaging changes doesn't mean that it's necessarily what's causing you pain. As clinicians, how do we differentiate that? How do we actually then address that? And at what point are we going to make the decision that, those changes are relevant and we need to maybe look at either some further medical or surgical input?
Yeah, I think there's two things there, because obviously one of it is based on your clinical assessment. I think the other one that's really hard, though, is based on patient perceptions, because the reality is a lot of patients do love to identify very, very strongly with the MRI.
With a clear diagnosis. I have hip dysplasia, and it's like, yeah, so. And
there's something also very alluring that seems, like, I guess, intellectually impressive or professional. If you have, someone shows you a scan, they go, you see this, little mark here, yeah, that's indicative
of... What do you think that is? Because it's just wank, isn't it?
Of intellectual masturbation, I guess, yeah. Look, it's one of these things where I guess it gives you some type of... authority. And the reality is it also makes things much more black and white, and people like that.
People love the certainty of it, don't they?
People do love the certainty. The only concern with that is when, for instance, they do get surgery and they don't have a good outcome. So...
Yeah, well, that's an interesting one, because we fix the problem.
Yes.
But obviously there's other reasons why you're getting pain. It's like, well, maybe we should have explored those other reasons before having the surgery.
Yeah, exactly. And then you can start talking about, like, well, we did conservative management, but did you exhaust all types of conservative management? But I think that's one point, and then the other one is the clinical picture. Because, you mentioned briefly at the start of the podcast that you had a patient recently who didn't have any of the clinical signs of femoroacetabular impingement or, say, labral pathology. And the other thing I find though too is how many people do you find who have, for instance, a positive Fadir type test that's meant to be impinging the hip, yet you apply some type of training intervention or might even be some type of manual therapy, and over time you see a reduction in that symptom. So clearly, it's not just purely to say that that is 100% sensitive and specific to be indicative of, say, a labral pathology, because we can clearly change the arthrokinematics of the joint that then influence how that femoral head moves within the acetabulum if we're thinking about the hip, that determines whether you actually get that impingement type symptom or not. Because, if we're applying exercise modalities, we're not changing the morphological structure of the joint. I mean, we may over time, but that may take several months to years. But we certainly can alter the tension developed through the different myofascial chains around the hip that then influences the sliding, gliding of the joint itself.
Yep.
And I think the other really important one too is, even if they do present with some of those symptoms, do they have indications where there is essentially structural failure of the joint? So, like, are they actually giving way of their joint where, they may take a step and all of a sudden they're on the ground because they get complete inhibition and significant pain from the fact that a joint structure is so symptomatic and structurally unstable? Or do they get very painful clicking or clunking that is, again, indicative of a significant tear within a cartilage structure that then influences the ability to for that tissue structure to stay in place and stabilize the joint. So these are useful things to take into consideration to think of, okay, do I need to be cognizant that this may be some type of, that particular finding on their scan is relevant to their presentation?
Yeah, I think that's a key thing of, like, you want to build up your clinical picture before you even have the imaging. I think for me, it's always one of those things of, do they have all of the pieces that you would say, yes, they're getting clear mechanical signs of this behavior. They're getting these clear symptom, whether, as you said, instability. They're getting, these very clear incidents that would suggest that there is some change to the tissue itself, whether that be articular tissue, whether that be tendon tissue. And then you go through the process of getting the imaging completed that potentially confirms your clinical picture.
Yes, and I think that's a really big thing.
It's actually getting quite annoying. It's happening quite a bit. The patients now are becoming much more forthright in saying they want to get imaging done and pushing GPs, pushing us to get imaging done before there actually is even potentially clinically relevant reasons to do so.
Yeah, I mean, and part of that comes to expectations of timelines for how quickly people should get better, because I think sometimes people's expectations can be unrealistic. But yeah, I mean, look, the reality is that problem isn't going away anytime soon. I think the one really important thing to do, and like you mentioned it before, like you actually showed the article to your patient. I have a folder with all these articles related to, tendon changes, cartilage changes, disc changes, so that I can actually show them, like, this is actually a very common finding, and it's particularly prevalent for your age group if you're older. So I think that helps to show people that this is something that two things. Is this actually related to your symptoms right now? Maybe, maybe not. But again, and I mentioned this before, if you get better, we might scan your hip or your knee or your Achilles tendon in 6 months' time, and it's probably going to show a similar finding, but you're asymptomatic. So, and that, I think, it can be very useful to show people, like, this is not something that is going to lead to, disability and a bad outcome unless you get surgery.
Yeah. I think in terms of how you manage it then, like, say, for instance, they do have findings, but the clinical picture maybe doesn't fit. What's the pathway that you're going down, not only with the communication you're giving the patient, but also the steps that you're taking to try and get to the point where potentially the clinical picture has changed, yet obviously the imaging is probably going to be exactly the same?
Well, I think the approach that you take is similar to whether you think there is some indication of the intra-articular tissue being related to their pain or not, is trying to understand why someone's developed this problem in the first place. Because even if you don't necessarily think even if you do think it's related to an articular structure, or even if you think it's something extra articular, the process that you need to go through is similar in going, what deficits do I identify or see in this person that's led to the development of their symptoms? And this is something that we've talked about plenty of times before on the podcast, where there are several things that we can think about and look at with regards to looking at their mechanics, their tissue capacity. But I think also too, and this is, I think, really important when it comes to articular or tendon type problems, is thinking about some of those systemic factors as well. And I think that actually hasn't been explored enough yet. I don't think we have really fully understood or appreciated that if we're going to maximise outcomes in people who have these type of problems with conservative management, we need to extend it beyond just the mechanical load that we apply or exercise interventions, because it seems that that may not necessarily be the only factor, or it's very limited in the response that they get to it if they don't have the appropriate nutrient uptake or metabolic environment to allow the cells to respond to the mechanical signal.
It's very funny because this is exactly, this discussion is what happened last week. And I was sitting there getting really pissed off because I was like, there's a lot of surgery going on for, say, osteoarthritic changes or injection therapies or whatever it is that are happening because people are just fucking lazy. And I know that that's...
Do you think a part of the issue, though, too, is it hard? Is there limited interest in looking at pure lifestyle changes to
of course
have good outcomes, because you can't patent that,
There's not money to be made in that. There's also... it's not sexy in any way at all. Like if you say to someone, okay, I need you to drastically change your diet. I need you to exercise more. I need you to stop doing these activities that you enjoy doing. And you need to keep doing that for the next 30 years until you die. They're probably going to say, I'll just take the knee replacement.
Well, that's one of the issues we have living in the technological age, because we are expecting technical solutions to every problem we have. And the other issue is we have an expectation that it happens now.
Yes.
And it's actually, like, we've talked a little bit about this, and even we've talked about it just privately, where I think that's one of the issues I see at the moment, where we're seeing this explosion of AI, for instance. And you hear these people saying that AI is going to solve cancer and osteoarthritis. And look,
it might.
I have no idea, obviously, myself. But it feeds into this narrative that people are like, oh, it's all fine. We're going to find all the solutions now because AI has all the answers. And look,
it might be the case.
I hope that we do find make a lot of medical breakthroughs. But I also then, I won't go down that rabbit hole of thinking about, is that actually the best way we approach it as a society? But
no, but I think it feeds into, as you said, this concept that people believe that technology will create quick solutions because they are not willing to take... The funny thing is, it's the tried and tested road, but they're not willing to take it because it actually requires some difficulty and consistency and hard work.
And let's also be clear here too. I've definitely seen some obviously very good outcomes with people who've had joint replacements. It can be a real game changer. But
I think that there's some, and don't get us wrong, there are some really clear indications when people will do much better in those environments.
Yes.
But there's been a number of people that and we had one actually recently. There's a patient, an older patient, had a knee replacement, and the pain that he was getting was very mild. Like very mild. And to be honest with you, I think most of it was patellofemoral pain. But he was adamant that it was better just to have the surgery done.
And understand too that you still might have ongoing problems, because there are people who get joint replacements but who still have ongoing hip pain, knee pain. They start developing back pain because there are some clear biomechanical changes to the loading. So it's not as simple as going, great, I've had the joint replacement, I have no pain and I'm back to 100% function. Like, you have to remember that you do have a prosthesis in you that does lead to changes throughout the whole kinetic chain and may also impair the things that you still can do. So it would be naive to think that it is an ultimate solution that is foolproof. And again, that's not to dismiss that it does have clearly good benefit. But I think people need to understand that there are implications to those type of very severe invasive interventions.
I think the good thing is that where a lot of the technology is going, this did come out of that conference last week, is that they're looking for solutions. And I think that they're getting excited about, they call it like orthobiologics. You know, it's these sort of different types of injections, and people are really excited about things like mesenchymal stem cells and, you know, these different factors, the PRP and all these different factors that they can inject into, say, a joint or a tendon. But whether that comes to create a solution, who knows? It's one of those things that it has some benefits in some situations and not in others. But the thing I do agree with, and I think is good with that, is often people are looking for these solutions because they know that there are people in the middle who just need a little bit of help with managing the pain. And if they can get better function at that time, they will be able to make more lifestyle changes, right? One of the researchers, Jane Fitzpatrick, that spoke and was quite strong. She has major bias because she works for an orthobiologics company, and is high up there and is doing a research for them through Melbourne Uni. But she said, like, if you've got someone who's got grade 2 or grade 3 changes to their joint, in terms of osteoarthritic gradings, they're not really especially if they're, say, around 45 to 50. You know, and these are usually those people that have had very heavy manual labour jobs and now maybe have some metabolic changes and their joint has degraded. But they're not really a candidate to have knee replacement because they're too young. You know, they're too active. They're not really at the point where you're going to have multiple revisions, which is the likely case that happens with something like a knee replacement, you know, that the joint will last for maybe 15 years. It's getting better, but if that person lives to 80, they've got to have it done twice.
Yeah.
And that in itself is something that you need to consider. And so they're doing it for the right reason. They're trying to find solutions for people that are in that middle ground that maybe allow them to then go and do more of their clinically, you know, managed conservative treatment.
Well, something I thought of then too is, do we need to think about people who start developing a bit of hip pain, a bit of knee pain, a bit of shoulder pain, who are, you know, in the general population, as this as being a warning sign?
Yeah.
Because you mentioned this before, and we've described that something like osteoarthritis or some of these degenerative changes that can happen in tendons, and this is for the general population.
I think that's a really good way of looking at it, Jack.
Yeah, because
these are warning signs.
Yeah, like putting aside the person who, for instance, was in a motor vehicle accident and they obviously
they've destroyed themselves,
destroyed their knee or their hip, and they need a joint replacement. For the majority of people, this has happened gradually. Do we need to think of this too as another type of chronic disease? Things like, when we think about chronic disease, we talk about things like cardiovascular disease, type 2 diabetes, neurodegenerative diseases, even probably cancer. We seem to have all predispositions where some people are more likely to get a certain type of chronic disease over others just because of, I guess, genetic, environmental factors. That we need to look at this as going, you need to make fundamental changes to your health, not only to help your hip pain, but actually potentially prevent the development of other chronic diseases that may lead to much further morbidity. And that, again, requires a real change in how people perceive it, because the pain is just a symptom to a more underlying systemic problem.
Yeah. Yeah, I think that's a really good way of looking at it. It's a warning sign that you can either heed or you can ignore. Yeah,
no, exactly. And I mean, I guess we all need sometimes to pay attention to those warning signs and go, is there something not right here? Do I actually need to make a shift or a change to make sure that this doesn't develop into something more worse, or, God forbid, some other type of pathology comes up because of it too?
All right, Jack, I think we've probably covered off on most things there. We hope people have gotten a reasonable understanding of how they might approach someone who does present with pain, and maybe their symptoms aren't matching even what the imaging that they've had done. don't, and as we said just then, we don't want people thinking that we're anti, medical input or surgery. If it's indicated, it's indicated, and those clinical symptoms are matching, then it's definitely something that should be explored with some, veracity. Don't hide from it. But also, if it's not matching up, then you need to ask yourself the question, why does this person have this pain? Maybe it's not related specifically to the pathology that we see on imaging, because as we've highlighted, it doesn't matter where in the body. There is pretty strong evidence that there are lots of people who have pathology that is not actually the driver of the pain that they get.
Absolutely. And I think something that I have found useful, and it's not always foolproof, but explaining that to patients and actually showing them the research behind it, it's actually a very powerful thing when they can see the numbers to go, oh, wow, okay, this is a very common thing you see in asymptomatic individuals, and perhaps I don't need to jump to conclusions about becoming too fearful based on what the radiological findings say.
Thank you once again for joining us. If you have any questions, feel free to reach out to us via our website or any of our social media channels.